Hello. Today we are going to discuss the principles of inhaled anesthetics. Note that this is not a comprehensive overview of inhaled anesthetics, and we will not be discussing the properties of individual drugs. Rather, this podcast is intended to help you develop a systemic understanding of the core pharmacologic principles of inhaled anesthetics, which will support your learning of the various anesthetic drugs. By the end of this podcast, you should understand what general anesthetics are and list the 5 primary anesthetic effects, be able to describe how inhaled compounds achieve anesthetic effects in the body, characterize the pharmacokinetic properties of inhaled anesthetics, and understand minimal alveolar concentration, also called MAC, as it applies to inhaled anesthetics. A natural place to start our discussion is by considering what anesthetic drugs are. The word anesthesia is thought to have derived from the Greek an, meaning not, or the absence of, and aesthesis, meaning feeling or sensation. Accordingly, anesthesia means not feeling, or the absence of sensation. A state of anesthesia is characterized by 5 primary effects, including unconsciousness, amnesia, analgesia, inhibition of autonomic reflexes, and skeletal muscle relaxation. However, no single drug is capable of producing all of these effects, so combinations of drugs are needed to attain anesthetic effects. Broadly, general anesthetics function through one of 2 mechanisms. Either they enhance inhibitory activity through inhibitory transmitters like GABA and glycine, or they attenuate excitatory activity, reducing the action of excitatory neurotransmitters like glutamate or acetylcholine. However, keep in mind that most anesthetics likely act through multiple mechanisms, many of which are incompletely characterized. One way to divide general anesthetics is by their routes of administration. Therefore, anesthetics can be thought of as either inhaled or intravenous. In today's podcast, we will focus only on the principles of inhaled anesthetics. Intravenous anesthetics are discussed in other parts of the course. To begin our exploration of inhaled anesthetics, we should remind ourselves of the pathway of these drugs through the body. Since these drugs are inhaled, they enter pulmonary circulation through the lungs, where they diffuse through the thin-walled alveoli to enter the bloodstream. From there, anesthetics reach various tissues where they exert their primary effects in the brain, spinal cord, and skeletal muscle. Some anesthetic is also stored in fat and undergoes limited metabolism and excretion in the liver and kidneys. Eventually, anesthetics return to the bloodstream and are largely eliminated via exhalation through the lungs. The core principles of pharmacology help us describe this journey in another way. The anesthetic is absorbed through passage from the lungs to the blood, distributed as the blood delivers anesthetic to the tissues, minimally metabolized, in some cases, by the liver, and eliminated mostly by the lungs. This pharmacokinetic approach will guide the following discussion. Absorption, or uptake, of an inhaled anesthetic depends primarily on ventilation parameters and the diffusion of anesthetic from the alveoli to the pulmonary circulation. A higher partial pressure of the anesthetic results in higher absorption, since a greater fraction of the air inhaled by the patient contains the anesthetic compound. For example, 300 millimeters of mercury of nitrous oxide will have slower anesthetic uptake compared to 500 millimeters of mercury of nitrous oxide, even though the patient is breathing in the same normalized barometric pressure. This effect is predicted by Dalton's law of partial pressures. Similarly, a higher tidal volume or respiratory rate will increase the absorption of an inhaled anesthetic, since a higher concentration of the drug will be delivered more rapidly. Finally, the fraction of alveolar versus inspired concentrations of an anesthetic determines the extent to which an anesthetic enters pulmonary blood circulation as opposed to remaining in the alveoli. In short, the more rapidly the alveolar concentration of the anesthetic approaches the inspired concentration, the more of that anesthetic that has diffused across the alveoli and into the bloodstream, increasing total anesthetic absorbed. These 2 graphs from Katzung's pharmacology demonstrate these parameters across a few conditions, though it's easier to think of these in terms of the speed of induction rather than absorption. In the first graph, we see that higher ventilation rates increase the relative fraction of alveolar anesthetic concentration, leading to faster induction. In the second graph, we see a comparison of the FA over FI ratio across a few inhaled anesthetics. The least soluble agents equilibrate between alveolar and inspired concentrations more quickly, reflecting faster induction. Distribution is largely influenced by a compound's blood-to-gas partition coefficient. The more hydrophilic a compound is, the more soluble it is in blood. The more soluble it is in blood, the higher affinity it has for remaining dissolved in blood, rather than entering tissues in which the compound has its effects. Therefore, an anesthetic with a higher blood to gas partition coefficient will have a slower distribution and slower speed of induction. Similarly, an anesthetic with a lower blood to gas partition coefficient will have a faster distribution and faster speed of induction. Again, the more soluble an anesthetic is in blood, the less it is able to enter into tissues like the brain or skeletal muscle, where it should have its primary anesthetic effects. This figure from Katzung's pharmacology depicts the blood to gas partition coefficient in another way. It shows that nitrous oxide, an anesthetic with a lower solubility in blood, more rapidly distributes out of the blood and into the brain. By contrast, halothane, with a higher solubility in blood, distributes out of the blood and into the brain much more slowly. Another way to think of this is that the size of the blood compartment for nitrous oxide is much smaller for nitrous oxide than it is for halothane. Most inhaled anesthetics are eliminated unchanged and exhaled by the lungs. However, small proportions of some inhaled anesthetics are metabolized by the liver in cytochrome P450 reactions that may contribute to their toxicity, including that of sevoflurane and halothane. Once again, elimination is largely handled by the lungs through the same pathways we discussed earlier for absorption and distribution, but in the reverse direction. Thus, a compound with a lower blood to gas partition coefficient will be rapidly distributed back to the lungs where it will be exhaled. Other components of elimination of anesthetics are complex as they reflect differences in the pharmacokinetics during induction versus emergence of anesthesia, so they are not explored here. In summary, we have discussed pharmacokinetics of inhaled anesthetics, covering the principles of absorption, distribution, metabolism, and elimination for these drugs. While we have mostly discussed the pharmacokinetics of inhaled anesthetics, there is one pharmacodynamic property of inhaled anesthetics that is important for a systemic understanding of these drugs. This property is referred to as the minimal alveolar concentration, also known as MAC. The MAC is a measure of a particular anesthetic's potency, meaning the concentration of a particular drug needed to obtain a particular effect. For MACs, this is measured as the concentration that produces immobility in 50% of patients exposed to a noxious or painful stimulus. You will commonly see this value expressed as a percentage of the total pressure that the anesthetic's partial pressure comprises. Anesthetics with a lower MAC, then, have higher potency, since the smaller partial pressure of the anesthetic is required for the effect. To a first approximation, MACs can be thought of as additive, and that multiple inhaled anesthetics can be used in concert to arithmetically increase anesthetic potency. This table samples a few MAC values expressed as percentages for some common anesthetics. Note that nitrous oxide has a MAC of greater than 100%, meaning that even at a theoretical maximum of nitrous oxide administration, half of patients would not be immobile to noxious stimulus. Therefore, nitrous oxide, having a high MAC, has a very low potency. Finally, test yourself with this table from Katzung's pharmacology. If you are able to understand this table and compare the potency, distribution, metabolism, and other values of this table from one major drug to the other, you have successfully met the learning objectives for this podcast.